Hello and welcome to Anatomy and Physiology. Today we will be covering the peripheral nervous system, which is Chapter 21 from your textbook. The lessons for Chapter 21, Section 1, are to discuss the generalized structure or branching of a typical spinal nerve, identify the location of the four major pairs of plexus and give examples of nerves that emerge from each, and describe the concept of dermatomes and myotomes and explain why they are clinically significant. Okay, and then we're going to cover an overview of the spinal nerves. Um, so a quick overview. As you see on the slide, there are 31 pairs of spinal nerves. And don't worry, I have images on the following slides. We have 31 pairs of spinal nerves. They're connected to the spinal cord, and they're broken up by the following division. 8 cervical nerve pairs, 12 thoracic nerve pairs, 5 lumbar nerve pairs, 5 sacral nerve pairs, and 1 coccygeal nerve pair. And I've got images that I've added to the slide that are not in your current slides so that you can get a better understanding of this. So, structure of the spinal nerve, right? Each spinal nerve attaches to the spinal cord by a ventral root and a dorsal root. We have what's also called a dorsal ramus and a ventral ramus. The ventral ramus is a little more complex than the dorsal ramus. And we also have what are called sympathetic rami. And these are follicles that are formed by splitting and rejoining the autonomic fibers. Let's go ahead and jump into some good stuff. All right. So here we see two images of the thoracic spinal nerves, or one image is figure 21-3 in your textbook. Note that it shows the ventral and dorsal roots that join to form the spinal nerve. But let's discuss the generalized structure or branching of a typical spinal nerve using this diagram from your book. So first we have roots. Right? We have the dorsal root or posterior root, and this carries sensory information from the body to the spinal cord. It contains dorsal root ganglions, which houses the cell bodies of sensory neurons. We sort of discussed that in the nervous system chapter, or we overviewed that. Then there are the ventral roots or the anterior roots, and these are the roots that carry motor information from the spinal cord to the muscles and to the glands. We also have spinal nerves. So after emerging from the spinal cord, the dorsal and ventral roots, they merge to form a spinal nerve. And this nerve is mixed, meaning it carries both sensory and motor fibers. The rami, as I discussed before, we have the dorsal ramus and the ventral ramus. The dorsal ramus is the branch that innervates the muscles and skin of the back. And the ventral ramus, this is the branch that innervates the muscles and skin of the limbs and the anterior trunk. Remember, I also said the ventral rami is a little more complex, so it forms the major nerve plexes, such as the cervical, brachial, lumbar, sacral, and we'll go into those a little bit more detail further along this presentation. We also have the meningeal branch. We discussed the meninges in the previous chapter, but the meningeal branch is the branch that re-enters the vertebral canal. It innervates the meninges, the vertebrae, and the spinal ligaments. And then we have finally the rami communicantes, right? These are the branches that connect the spinal nerve to the sympathetic trunk. They're part of the autonomic nervous system, and they aid in regulation of visceral functions. What you should know from this image is to be able to label the dorsal and ventral roots, the spinal nerve, the dorsal and ventral rami, the meningeal branch, and the rami communicants. Also note that the dorsal root should lead into the dorsal root ganglion and merge with the ventral root, and that forms a spinal nerve, which then splits into the dorsal and ventral rami. So if you take that away from this slide, that's good for identification. All right. Cervical and brachial plexus. Let's go ahead and jump right into the plexus. I said I added images. This image is not in your slides from the publisher. I added it. I found it from the publisher and put it on there. But the plexus, I mentioned there's four. So there's four major pairs of nerve plexus, which are the cervical, the brachial, which are mentioned here on this slide. There's also the lumbar and the sacral plexus. So what we're going to do in the next section, or this section, is we're going to identify their locations and some of the key nerves that emerge from each. So let's start off with what we see here, the cervical plexus, right? So this starts high in the neck, and it's between vertebrae C1 through C4. We did discuss the vertebrae last in chapter 20. The brachial plexus, this starts off in the lower part of the neck and covers the shoulder region, so from uh, vertebrae C5 to T1. And then the lumbar plexus, this starts in the lower back, and it starts off from lumbar vertebrae 1 to lumbar 4, L1 to L4. And then the sacral plexus, which is in the pelvic region, this starts off at L4 and uh, finishes off at S4. And just a big overview of where these cervical and brachial plexus start and finish. All right, so here we see an image of the cervical plexus. This is figure 21-4. It shows the ventral rami of the first four cervical spinal nerves, C1 through C4. This is just from your textbook and the caption from the textbook. But let's go a little bit more into detail, right? So cervical plexus, C1 through C4. We said it's located deep in the, it's deep to the sternocleidomastoid muscle. I may have mentioned that last in chapter 20, right? So in the neck. There are key nerves that are located here. The phrenic nerve, the lesser occipital nerve, and the great auricular nerve. Remember that the phrenic nerve, this innervates the diaphragm, and that's essential for breathing. That's what the diaphragm's for. The lesser occipital nerve, this innervates the skin of the scalp behind the ear. And then the great auricular nerve, this innervates the skin over the parotid gland and behind the ear. And we're doing good. All right, this is figure 21-5. The brachial plexus is again out of your textbook. And figure A says from the 5 rami C5 through T1, the plexus forms 3 trunks. So let's kind of get into the architecture of the brachial plexus. So the brachial plexus starts off at C5 and ends at T1. It's located partly in the neck and partly in the axilla. Axilla is just another word for your armpit, but we're going to say axilla in this class. The structure of the brachial plexus, it's like a nice highway, right? You're probably looking at the picture I have there, code beer, Lone Star, rami, trunk, division, chords, branches. There's a way to memorize all this, and I'll tell you how to memorize it using this um, little eponym. I think it's an eponym. All right. Anyway, where was I? The roots, right? So brachial plexus, it begins with 5 roots, and these are the anterior rami of the spinal nerves, C5, C6, C7, C8, and T1. Then we have the next section, which is the trunks. These 5 roots, they merge to form 3 trunks. There's an upper, middle, and lower trunk. The upper trunk's formed by the union of C5 and C6 roots. Middle trunk is a continuation of the C7 root, and then the lower trunk is formed by the union of C8 and T1 roots. This was a pretty big deal to memorize in gross anatomy. So it wasn't just memorizing a diagram, though. We had to actually find the structure in the cadavers. Right, so the next section is the division. So each of the trunks splits into 2 divisions. We have the anterior division and the posterior division. The anterior division, this supplies the flexor muscles, and the posterior division, this supplies the extensor muscles. And then we have finally I'm sorry, not finally, next is the chords. And these are where the divisions reorganize to form chords, right? We call them chords. And they're named according to their position relative to the axillary artery. So you have the lateral chord, the posterior chord, and the medial chord. The lateral chord, that's formed by the anterior divisions of the upper and middle trunks. The posterior chord, that's formed by all 3 posterior divisions. Then you have the medial chord, and that's formed by the anterior division of the lower trunk. Right? So then we end up with, I have branches saved for the next slide, but I'll go ahead and tell you how to memorize these sections, right? So how do you just remember rami, trunk, division, chords, branches? There's again, I think it's called an eponym. It says real Texans drink code beer. So I'm not a fan of those, but if it helps, since our class is kind of crunched, you're actually learning a lot of material in a short amount of time. Real Texans drink cold beer. Rami trunk division chords branches. All right. Hopefully that helps. I think it will help. All right. This is figure 21-5 from your textbook. It shows the brachial plexus. Right. So figure B is the nerves of the brachial plexus. So let's get into those key nerves. Or the branches. So this is the part that I left off the last slide. So everything finally ends in these branches. And so the cords give rise to the major nerves of the upper limb. And these key branches or these nerves are the following: the musculocutaneous nerve or musculocutaneous nerve, and that arises from the lateral cord and it supplies the anterior arm muscles, the biceps brachii, and the skin of the lateral forearm. Then you have the axillary nerve, and this rises from the posterior cord, and this supplies the deltoid and the teres minor muscles, and as well as the skin over the shoulder. So if you exercise, you can kind of relate to these, at least at being able to identify the muscles. The radial nerve is the next one, and that innervates the posterior arm and the forearm muscles and the skin in the area. And then we have the median nerve. This innervates most of the anterior forearm muscles and some of the hand muscles, and we'll get into more detail on that as well. We have the ulnar nerve that innervates some anterior forearm muscles and most intrinsic hand muscles. And I have another slide so we can go just a little further down into the hand. There it is. So this is just figure 21-5. This is, again, from your textbook. This is C, figure C of 21-5, and it just shows innervation of the hand. So that brachial plexus that we talked about, it starts off as a network of nerves and it originates from the spinal nerves and the neck and supplies the upper limb, right? It's this complex structure. When you look at it, you can make an analogy of a highway where things are getting on and off and merging and so forth. So it's complex, and it involves those different divisions or those different sections: the roots, the trunks, the division, the cords, and the branches. Real Texans drink cold beer of the nerves. So we're going to go just a little bit further down now and talk about where these branches, specifically the radial nerve, the median nerve, and the ulnar nerve, how they innervate the hand, and a little bit of clinical significance on these. All right. So the radial nerve, this arises from the posterior cord. It supplies the posterior arm, the forearm muscles we mentioned before, as well as the skin of the posterior arm and the forearm and the hand. The median nerve arises from both the lateral and medial cord. This supplies most of the anterior forearm muscles and some hand muscles, also the skin of the lateral palm of the fingers, and then the ulnar nerve, again, which arises from the medial cord, and that supplies some anterior forearm muscles and most intrinsic hand muscles, as well as, again, the skin of the medial hand and the fingers. There's some clinical significance. I'll go ahead and cover that now, but yeah, I'm just going to cover this now. Clinical significance of understanding these innervations. So specifically the brachial plexus, it's crucial for diagnosing and treating nerve injuries in the upper limb, and hand. I was going to say in hand, but that's part of the upper limb. So if you have injuries to roots or the trunks, for example, you can develop something called Erb's palsy or Klumpke's palsy, and you can look up images to see what these actually look like. Erb's palsy is an injury to the upper trunk, C5, C6. It causes weakness in the shoulder and the arm. Klumpke's palsy, this is injury to the lower trunk, C8 through T1, and that leads to weakness in the hand and the wrist. The doctors can actually tell what area of the plexus is injured based on where the weakness lies. You can have injuries to the cords or the branches themselves. You can have radial nerve palsy. Some of these are in your textbook, and some of these are just a little extra information for you. Yeah. So you can look at the textbook and find some good images on some of these. There's one or two that I think I just added myself. radial nerve palsy. That's where we're left at. So that's wrist drop, right? And that's due to an inability to extend the wrist and the fingers. So have you ever seen someone whose wrist is always in a drop position? Carpal tunnel syndrome. This you might know or have heard of. It's a compression of that median nerve that leads to numbness, tingling of the thumb, the index finger, the middle finger, and then the lateral half of the ring finger. Then we have the ulnar nerve injury, right? So one injury from each nerve. This leads to something called claw hand, and it's due to weakness in the intrinsic hand muscles. And it is just what it sounds like. It's someone who's got their hand, I don't know if you can see my hand, in a claw position. Yeah, claw hand. It literally does that. Okay. All right, let's go ahead and move to the next section, which is the lumbar, sacral, and coccygeal plexus. Just going to read here from the slide and get us started. So the lumbar plexus, located in the lumbar region of the neck, near the psoas muscle, and it's formed by intermingling fibers of L1 and L4. Sacral plexus, located in the pelvic cavity of the anterior surface of the piriformis muscle. Piriformis just means pear-shaped. And it's formed by intermingling fibers from L4 through S4. I never thought it looked like a pear. I mean, I dissected it and it's like, I don't see a pear. But yeah, I won't get off topic, I promise. Coccygeal plexus formed by the last sacral spinal nerve, S5, and a few fibers from the S4 joining with the coccygeal nerve. So let's go ahead and jump into lumbar sacral coccygeal plexus. Exciting, right? Yes. All right, this is figure 21-6 from your textbook, and it just shows the lumbosacral plexus. We got part A, or image A of 21-6, the plexus formed by the combination of the lumbar plexus with the sacral plexus, and let's jump right on in. So the lumbar plexus, remember we said it was L1 through L4. It's located within the psoas major muscle. Key nerves in this area are the femoral nerve. You might have heard of that one. The obturator nerve. The femoral nerve, this innervates the anterior thigh muscles and the skin in the area. And the obturator nerve, this innervates the medial thigh muscles and the skin. One of my favorite nerves, and because it innervates one of my favorite muscles, the gracilis muscle. Great muscle. Great stretch. Like you stretch, and it's like it's a real good feeling when you stretch the gracilis muscle. Anyway, I won't get off topic. Sacral plexus. Again, L4 through S4, as we said, that's located in the pelvis, and that's anterior to the sacrum. The key nerves in this area are the sciatic nerve, and I'm sure you've heard of this before this class. That's the largest nerve in the body. It innervates the posterior thigh. It splits into the tibial and the common fibular nerves, the peroneal nerves. The other nerve in this area that's critical, or not critical, but it's key, is the pudendal nerve, and this innervates the muscles and skin of the perineum. All right, here we have figure 21-6, and it shows the lumbosacral plexus. This is figure B, anterior view of the lumbosacral plexus nerves, and figure C, posterior view of the lumbosacral nerve plexus. Okay, so jump right in. The lumbar and the sacral plexus, they innervate the lower limb, and that includes the foot. So the lumbar plexus, again, L1 through L4, and the sacral plexus, L4 through S4, they give rise to several nerves that contribute to the sensory and motor innervation of the foot. And I have another image, a few slides down, so we can talk about that innervation of the foot. But the lumbar plexus, it's formed within the psoas muscle, or psoas major muscle, and that contributes to the innervation of the foot primarily through the femoral and obturator nerves. The femoral nerve that branches from the L2 to L4, excuse me, it's broken down into the, or it splits off into something called the saphenous nerve, and this is the branch of the femoral nerve that provides sensory innervation to the medial aspect of the foot and the ankle. We have the sacral plexus, the next plexus, and that's located in the pelvis, and it contributes to the innervation of the foot through the sciatic nerve and its branches. The sciatic nerve, which extends from L4 through S3, it splits into two major branches in the posterior thigh. So we have the tibial nerve, and we have the medial calcaneal branch. Right? So the tibial nerve, this nerve continues down the posterior leg and into the foot, and it divides further once it gets to that point. It divides into the medial plantar nerve and the lateral plantar nerve. And the medial plantar nerve supplies motor innervation to the abductor hallucis. Hopefully you remember your muscles from A&P 1. The flexor digitorum brevis, the flexor hallucis. I said hallucis, sorry. I was thinking hallucis. Hallucis. Let me start over. The abductor hallucis, flexor digitorum, brevis flexor hallucis. Okay. Hopefully, look in the book. I may have missed one. And the first lumbrical muscles. Hallucis. I said hallucis. Hallucis. Um, sorry. That was funny. That was a funny A&P joke. What does it do? So it provides sensory innervation to the medial 3 and half the toes, and the corresponding part of the sole. The other one we mentioned was the lateral plantar nerve. This supplies motor innervation to the quadratus plantae, the abductor digiti minimi. I like that. Digiti minimi, which is your pinky toe. Digiti minimi. Well, anyway, I won't get off topic. The flexor digiti minimi brevis is the muscle that attaches to the minimi, digiti minimi. The abductor hallucis and the intercossae and the lumbricals, except for the first one. And what it does, the lateral plantar nerve provides sensory innervation to the lateral one and half the toes and the corresponding part of the sole. And I mentioned the medial calcaneal branch, right? This provides sensory innervation to the skin of the heel. Yeah, sometimes I get really rough heels and I can't feel my heel. It worries me. But then I soak it in hot water and, do the cleaning and you feel it again. Feels great. All right. But I won't go off topic. All right. I have stories. Let's talk about the common fibular nerve, or the perineal nerve. This is a nerve that wraps around the neck of the fibula and it splits into two. It splits into the superficial fibular nerve and the deep fibular nerve, perineal nerve. Right, the superficial fibular nerve that supplies motor innervation to the fibularis longus, the brevis muscles, and sensory innervation to the dorsum of the foot, except the area between the first and second toes. The deep fibular perineal nerve, or deep fibular nerve, or perineal nerve, this supplies motor innervation to the muscles of the anterior compartment of the leg, so the tibialis anterior and the extensor digitorum brevis muscles of the foot. It also provides sensory innervation to the skin between the first and second toes. The light's shutting off in my office, but I think it looks better. Actually, I'd look brighter. Okay. This is figure 21-6 from your textbook. It shows the lumbosacral plexus. This is figure D, innervation of the foot and ankle. I told you I was going to have a picture of that. So let's talk about a summary of the foot innervation. First with the medial foot, right? So we have the saphenous nerve. It's the branch of the femoral nerve. It's sensory to the medial aspect of the foot and the ankle. We have the dorsal foot that's broken down into the superficial fibular nerve, the deep fibular nerve, and the superficial nerve, fibular nerve. That's sensory to the majority of the dorsum of the foot, except for the web space between the first and second toes. The deep fibular nerve, this is sensory to the web space between the first and second toes, and then a motor to the extensor digitorum brevis. Long names, extensor digitorum brevis. Okay. and the plantar of the foot. Now, um, this is innervated by the medial plantar nerve, the lateral plantar nerve. The medial plantar nerve, it's um, a motor nerve to several what are called intrinsic muscles of the foot. It has sensory connections to the medial 3.5 toes and the corresponding part of the sole. The lateral plantar nerve, on the other hand, it's motor to most of the intrinsic muscles of the foot, sensory of the lateral 1.5 toes of the corresponding part of the sole. So then we have the heel, right? So this is, I mentioned this already, the medial calcaneal branches. This comes from the tibial nerve, and it just provides sensory to the heel. I told you my heel story. Clinical significance of this section. Next time I'll break up clinical significance into separate slides, but I've covered it here for this chapter. But it's understanding, like I said, understanding the innervation so that you can diagnose and treat conditions. And we'll talk about a couple of conditions. The first one being peripheral neuropathy. And this is just a condition, kind of like diabetic neuropathy. It affects the nerves supplying the foot, and this leads to sensory and motor deficit. So sensory, it's really bad, where they cannot feel anything with their skin. So they could literally step on a piece of glass and not feel the puncture or the pain. Um, Diabetic patients have told me that when that's happened, they felt something just wet. So they felt that, some cool sensation, and that was the only reason they looked, but they felt no pain when they stepped on something sharp. And just other nerve injuries. Sorry, let's get onto those ones. You can have trauma or compression to the tibial and fibular nerve, and that can lead to conditions like tarsal tunnel syndrome or foot drop, very similar to what we mentioned in the upper limb. And then we can have something called plantar fasciitis. It's common. It involves pain in the heel, and it can be associated with nerve entrapment. Okay, we're making good time. All right. Dermatomes. So dermatomes and myotomes, these are essential concepts in neuroanatomy, and they help understand the distribution of sensory and motor functions of the spinal nerves. So dermatomes, by definition, it's an area of skin that is mainly supplied by a single spinal nerve. Remember, there's 31 pairs of spinal nerves, and each pair innervates a specific region of the skin. We can map these out. I'll show you some images later on the maps of what we call dermatomes. And dermatomes are just mapped throughout the body, and it shows clinicians and helps them determine which spinal nerve or which segment of the spinal cord is affected based on the location of sensory changes. Myotomes, the definition for myotome is a group of muscles that is single spinal nerve root innervates, and each spinal nerve root provides motor control to a specific muscle. Uh, we also map myotomes. They're mapped similarly to dermatomes, but just remember they represent muscle groups rather than skin areas. All right, so this is figure 21-7 from your book, which shows segmental distribution of spinal nerves. It says a dermatome, this is from the caption, a dermatome is a region of skin supplied by afferent sensory fibers of a given spinal nerve. And it also gives a definition for myotome, or their definition. Myotome is a region of skeletal muscle innervated by efferent motor fibers of a given spinal nerve. So I left out the afferent and efferent, but hopefully you knew that from what we talked about in chapter 20. Okay, let's go ahead and jump a little deeper into this. Hopefully I didn't skip a slide. I clicked twice. Okay, this is figure 21-8. Ooh, I hope I didn't click twice. And this is from the caption in your textbook. Shows dermatome distribution of spinal nerves. Figure A, the front of the body surface. B, the back of the body surface. That's it. Okay. There's a clinical significance for knowing these nerves and knowing these dermatomes. For example, if you want to diagnose, not for example, if you want to diagnose nerve damage, correctly, you can test for sensation in different dermatomes. And what clinicians will do is they'll use this information to help pinpoint which spinal nerve or spinal cord segment can be damaged. Some uh, pathologies that you might be familiar with, the herpes zoster or shingles is something everyone has to get a vaccination for. Uh, I'm at the age where I have to get my uh, renew my vaccinations. All right. Anyway, herpes zoster or shingles. It's a viral infection that it awful it follows some dermatome pattern, and it leads to pain, leads to rash in a particular area, and in an area that's supplied by the affected nerve. This leads to a lot of discomfort. I'll leave it there. Uh, I've never had it, so I'm just saying what I know from it. All right. Okay. Referred pain. This is an interesting one. So understanding dermatomes will help explain what's called referred pain. So this is where you perceive pain in one location, but the actual source of the pain is actually in a different location. So if you see the image there where you got those dermatomes and you got sensation going from one part of the upper limb all the way across the chest, the thoracic region, all the way across the to the other limb, all of that one dermatome is innervated by one pair of spinal nerves. So your body can get confused if you have pain in one area when it's actually somewhere else. And we call that referred pain. All right. This is figure 21-8. 21-8. Right. Shows the dermatome distribution of spinal nerves. This is figure C, the side of the body's surface. Okay, let's jump into this one. So knowing the clinical significance here, uh, doctors will do motor function testing, and so they'll test strength of a specific muscle groups. They can determine by that they can determine which spinal nerve or segment of a spinal cord may be compromised. They can do a neurological examination uh, by testing myotomes. Right, it's part of a larger comprehensive neurological exam, and they use that to assess motor function, and they can identify potential nerve damage from from those tests. It also helps them to um, prescribe rehabilitation and treatment. So if you understand the myotomes, it's going to help you design some rehabilitation program that'll target those specific muscle groups affected by the nerve, so you're not doing things you shouldn't be doing or things that are not going to help you. So you know exactly what to do to strengthen those muscles. So what you see there in the diagram is just the areas and muscles innervated by a specific spinal nerve. And we can break these down to, hopefully you can see the little image to the left of the larger image where you see uh, cervical dermatomes, thoracic dermatomes, lumbar dermatomes, sacral dermatomes, all broken down. Um, excuse me. The cervical dermatomes, you can see they're broken down from C2 through C8. We got the thoracic dermatomes that goes from T1 to T12, T1 to T12. I'm having a hard time talking. The lumbar dermatomes start at L1 to L5, and the sacrodermatomes, they start at S1 to S5. They're broken down a little further. For example, the lumbar dermatomes, L3 um, innervates the anterior thigh. L5 innervates the dorsum of the foot. So there, you can get more specific into this, but this is kind of all you need to know for uh, this chapter, this section, and for an intro to A&P. All right, this is figure 21-9, again showing myotomes and body movement. This is again from your textbook. Myotomes are skeletal muscles innervated by one or more given spinal nerves. It says these examples show which spinal nerves innervate the skeletal muscles that produce the movements indicated by the arrows. So here we have figure A, B, and C from your textbook of figure 21-9. So remember we mentioned cervical myotomes are from C5 through C8. We have those in the shoulder. C5 is mainly for shoulder abduction. The C6 are for elbow flexion, wrist extension. C7 is for elbow extension, and then C8 is for finger flexion. So you see how we can start pinpointing or getting more focused on which nerve innervates what, and by looking at the myotomes, and it helps us isolate where to pinpoint the diagnosis. Okay. Oh, then we have lumbar and sacral myotomes from L2 through S1. L2 is responsible for hip flexion. L3 knee extension. L4 is for ankle dorsiflexion, and then S1 for ankle plantar flexion. So, doing all these movements will allow a doctor or clinician to determine if something is not well. All right. Next section, 21.2. That was 21.1. We are at 36 minutes. This is taking a long time. And this is only 40 slides. 21.2, section 2. Wow. Cranial nerves and the somatic pathways. So the objectives here are to identify the cranial nerves by name and give the generalized function of each, identify the basic principles of somatic motor pathways, and list and discuss several of these somatic reflexes that are clinically important. We did touch on this a little bit in the Chapter 20 nervous system chapter. Alrighty. So overview for this section, we're going to talk about cranial nerves. We have 12 pairs of cranial nerves. They connect to the undersurface of the brain, mostly in the brainstem. There are 2 cranial nerves that are not technically cranial nerves. I'll point those out later. And they don't originate in the cranium. Anyway, they're made up of bundles of axons. It says mixed cranial nerves, sensory cranial nerves, and motor cranial nerves. This is something else that I would expect you to be able to label and identify their function. And we'll just go through these. All right, so this is figure 21-10. I added this figure. Interesting. Okay. No, I don't know if I added this figure or not. It sounds like a figure I would have added. Yeah, so from the textbook, the caption in the textbook 21-10 illustrates cranial nerves, ventral surface of the brain showing attachment of the cranial nerves. So got a lot to talk about here. The cranial nerves themselves, we said there's 12 pairs of nerves. They emerge directly from the brain as opposed to spinal nerves, which emerge from segments of the spinal cord. Each cranial nerve has a specific set of functions, and that can be sensory, that can be motor, or that can be both. And we'll talk about those in a minute. Give me a second, my light's turned off. There we go. All righty. It's on a timer. Let's start off with the olfactory nerve, or cranial nerve number 1. And its function is, it's sensory. It's smell, right? Sense of smell, generalized function. The optic nerve, which is cranial nerve number 2, optic nerve 2. Its function is it's sensory, and its generalized function is for vision. The ocular motor nerve, I'm doing these in order so you can know that that's going to be 3. Cranial nerve number 3. Its function is motor, right? It's got motor in the name. And its generalized function is controlling eye movements. It includes constricting of the pupil, and it helps maintain your eyelids open. Cranial nerve number 4 is the trochlear nerve. Again, its function is motor, and its generalized function controls the superior oblique muscles of the eye, and it's responsible for downward, inward, and lateral eye movement. I won't try it. Cranial nerve number 5, the trigeminal nerve. This has two functions. It's both sensory and motor. The generalized function, when we talk about sensory, it functions to include facial sensation, so touch, pain, temperature. Um, it's involved in uh, kissing. The motor function part of it includes controlling the muscles involved in chewing. All right, the cranial nerve number 6, abducens nerve. It's a motor nerve, and it controls the lateral rectus muscle of the eye, and it's responsible for outward eye movement. I'm trying to do it now. Cranial nerve number 7. This is the facial nerve. It has both sensory and motor functions. It's another nerve that's included in the action of kissing. Um, and within the motor function, it controls muscles of facial expression. Right? So imagine you're taking a picture and you're doing one of those selfies. Its sensory function includes taste sensation from the anterior 2/3 of the tongue, and then the salivary and the lacrimal, which is the tear glands for secretion. The next nerve is, we're on 8, which is cranial nerve number 8, the vestibulocochlear nerve. Its function is sensory, and its generalized function is for hearing and balance, or your equilibrium. The next nerve is cranial nerve number 9, trying to keep these in order. The glossopharyngeal nerve, you can kind of tell what it is from the name, right? It's both sensory and motor, and its generalized function is for sensory, meaning, not meaning, but it includes taste and sensation from the posterior 1/3 of the tongue, and then sensation from the pharynx. It also has a motor function, and that includes controlling some muscles involved in swallowing, and also helps contribute to the salivary gland. So I'm trying to do it myself. Salivary gland secretion. In fact, I think I need some salivary gland secretion right now. All right. Cranial nerve number 10. I don't know why I always associate this with Las Vegas. 10, it's the vagus nerve, not the same kind of vagus, not spelled the same way. It has both sensory and motor function. Its sensory function includes sensation from the pharynx, the larynx, the thoracic and abdominal organs. Its motor function includes controlling the muscles that are involved in the voice, in swallowing, as well as aiding in regulating the heart, lungs, and the digestive tract. That was 10, vagus. Number 11, okay, is the accessory nerve, and it's a motor nerve, and it controls the sternocleidomastoid and the trapezius muscles, and these are the muscles that are involved for head movement and shoulder elevation. I always say that sternocleidomastoid muscle is one of my favorite neck muscles. You really have a lot of tension with that muscle. It's a large muscle, so I assume it would bear most of the strain. So anyway, the last one is cranial nerve number 12, the hypoglossal nerve. It's also a motor nerve, and this nerve controls the muscles of the tongue. That's why it has the name glossal in it. And it's also important for speech and swallowing. There's lots of mnemonics to remember this. Um, Again, I don't, what did I say before? Eponym? I don't know why I said that. Mnemonic. And I remember students actually tell me that as well. Sorry. Um, there's some mnemonics to remember this. There's a whole bunch. There's a text, not a textbook. There's a book that actually has nothing but mnemonics for remembering all of these clusters of muscles and nerves and arteries. Um, and it, yes, and they're in the right order from however you have to learn them. Yes, you can buy that book, and some people will study that book without actually learning. I'll give you one, but just try to you know how to count, you know numbers, and you know your own facial sensory and motor functions. I'm sure you can connect those two together without using a mnemonic. What did I say before? All right. So we said olfactory, optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibular, cochlear, glossopharyngeal, vagus, accessory, hypoglossal. So, and I didn't use a mnemonic, but I'll say it now. The mnemonic is, that's kind of, there's got to be a better one. You can Google some if you don't like this one. It's O to touch and feel very green vegetables. Ah, that's just, there's got to be something better. Um, hmm. Anyway, that is, use the first letter of each one of those words and you'll remember. When we want to talk about sensory, motor, or both, there's another mnemonic, and it goes like this. This one's actually a little bit better. It says, some say marry money, but my brother says big brains matter more. And that'll give you the sensory motor functions of the nerves in order. And that's it. Oh, that's not it. Sorry. Next slide. But stay away from mnemonics. Just use them to learn something and then throw it away and just make the connection between the cranial nerve, the name of the nerve, the function of the nerve, so forth. All right. So we're going to jump a little more into what these cranial nerves are. Um, the next few slides are talking about just the cranial nerves themselves. So what I did before is just kind of list them, kind of give you a nice rundown. Um, I think I covered most of this. Olfactory nerve carries information about sense, carries visual information from the eyes to the brain. Ocular motor. That's it. Okay, I'm going to go ahead and jump to these slides. Okay, this one is figure 21-11. This shows the trigeminal nerve. Remember, that's cranial nerve number 5 or 5. And if you look at the caption in the textbook, this is figure A and B. A says the route of trigeminal nerve and its major branches. B says the sensory fibers of the trigeminal nerve form 3 branches: ophthalmic, maxillary, and mandibular. Continuing with just kind of running through these, we covered these already in detail. Facial nerve, vestibulocochlear nerve, and the glossopharyngeal nerve, cranial nerves number 7, 8, and 9. A little more information on these. So like the vestibulocochlear nerve, it's both sensory. I think they meant to say both sensory and motor. So this would be one of the B's in your mnemonic. The glossopharyngeal nerve supplies fibers to the tongue, pharynx, and carotid sinus. Okay. This is figure 21-12 from the textbook. This is cranial nerve number 7. What it's illustrating here, or what the, yeah, what it's illustrating there. And yeah, I'm just going to go through these because we covered a lot of this in the that one slide. I think I covered everything in the one slide. This is, but again, because I don't have the figure names on there, figure 21-13, the glossopharyngeal nerve, cranial nerve number 9. Glosso, remember, means tongue. Pharyngeal means throat. All right. And here we have the last 3, vagus nerve, accessory nerve, and hypoglossal nerve. Cranial nerves number 10, 11, and 12. Okay. All right. One slide just on the vagus nerve, cranial nerve number 10. It says it's mixed with cranial nerve. The vagus nerve is a mixed cranial nerve with many widely distributed branches, hence the name vagus, which is the Latin word for wanderer. I wonder if Las Vegas means that. I've always been calling this the vagus nerve 10, and I always think of 10 when I think of vagus. It makes sense now. All right. This is figure 21-15. Here we see the accessory cranial nerve number 11. Um, they thought this was originally the vagus nerve, like it could be the vagus nerve. They couldn't handle what the vagus nerve does. But this is the nerve that originates in these cervical spinal segments, and it branches out to the trapezius and the sternocleidomastoid muscle. Sternocleidomastoid muscle. Whew. All right. I'll bring some water next time I do a lecture. Right now I got a slushy. It's not helping. Okay. All right. Oh, okay. Now, divisions of the peripheral nervous system, sensory, somatic motor nervous system. Okay. Now we're getting to some new stuff. So we have somatic motor pathways, and these are responsible for voluntary movements of skeletal muscle. Again, you're going to have to refer back to your A&P 1 for skeletal muscles. And the somatic motor pathways involve a series of neural circuits. They originate in the central nervous system and they end in the neuromuscular junctions of the muscle fibers. I put extra pictures on this presentation from the central nervous system all the way down to the neuromuscular junction. So I've added extra pictures here from your textbook so that they're your author's, your textbook's pictures. You can see yourself. Your original slides didn't have them. So there's a hierarchical organization. What you see there, this is like the higher centers, right? So we're starting off from the cerebral cortex, mainly the primary motor cortex. Primary motor cortex. I don't know why I'm having a problem speaking right now. My mouth is dry. Which cranial nerve is not helping me produce saliva? You answer that. What were they talking about? Deep primary motor cortex. That's responsible for initiation of voluntary muscles. We have intermediate centers. These include structures like the basal ganglia, the cerebellum. We mentioned those chapter 20, and they help coordinate fine tuning movements. I think we mentioned that as well in chapter 20. What else? Yeah, I think that's all we talked about in chapter 20. So this is kind of like a review. We have the lower centers. This includes the brainstem, spinal cord, and this contains the motor neurons that directly control the muscle contractions. Also something that we touched on in chapter 20, but now we're getting to see it from a different perspective. Right? We also have what's called a somatotropic organization. And so here, this is where the motor cortex itself is organized somatotopically. And what this means is that different regions correspond to the control of different parts of the body. And this is represented here in this illustration, where you see the motor homunculus, which is distorted representation of the body, and it's based on the amount of cortical area dedicated to a motor control for each part. We also have, once we get from this higher motor areas, is the descending motor pathways. And that starts off with the cortical spinal tract. And I know we mentioned that in the previous chapter. We didn't say too much about it, but it's the primary pathway for voluntary motor control. I think we just mentioned it and identified where it was located. Originates in the motor cortex. It travels down through the brainstem. It crosses over at the medulla. I think we mentioned the medulla. Yeah. Okay. And then we have two parts of it, the lateral cortical spinal tract and the anterior cortical spinal tract. These we didn't mention in the last chapter, but the lateral cortical lateral cortical spinal tract controls fine skilled movements and movements specifically from the distal limbs. The anterior cortical spinal tract controls movements of the trunk and the proximal limbs. We mentioned something called, this is also from chapter 20, the extrapyramidal tracts, and we'll see more of this in the next slide. Let me go to the next slide because I think I have a better picture. Yeah, there you go. All right. So you can see the descending motor pathways a lot better here. Sorry. The corticospinal tract, you can see it clear here. Lateral corticospinal tract, the anterior corticospinal tract, and we continue with where I left off at the extrapyramidal tracts, which you see in this slide. Sorry, I should have jumped to this slide. These are the pathways like the rubrospinal or the reticulospinal or the vestibulospinal and the tectospinal tracts. Now, I do remember speaking about those in chapter 20 in class. I don't know if we talked about function. I think we just talked about labeling, identification, where they're located. But they're involved in control of posture, balance, and coarse limb movement. I feel like we talked about it, but if not, it's okay to repeat. Here we do see the motor neurons, the upper motor neurons, and the lower motor neurons. So these neurons originate in the cerebral cortex, which I like this picture. This one's not in your slides. This one I added to your slides because I like the cutaways. So they originate in the cerebral cortex or the brainstem, and they project down to the spinal cord or the brainstem, and they synapse with the lower motor neurons, and they play a role in initiating, modulating, and controlling voluntary movements. The lower motor neurons, these are located in the anterior horn of the spinal cord. We talked about that in chapter 20 also. We had that cross section of the spinal cord. If you want to go back to look at that, you have a better picture in that chapter, where you can see the anterior horn enlarged in one of those pictures. And you can see the nuclei and its connection to the brainstem better in that picture. But these lower motor neurons innervate skeletal muscles, and they're responsible for executing movements as well. There's also a feedback mechanism, and we couldn't operate well without a feedback mechanism. If we didn't have a feedback mechanism, every time I wanted to move my hand up to grab something, it would just like go to one extreme or the other. So if I wanted to pick up something, it would go, and if I wanted to like grab something in the middle, it would just go all the way down. So we have feedback mechanisms to kind of tell you where exactly you are um, by location, by feel, everything. So the first one is a proprioceptive feedback, and these are made up of sensory receptors like muscle spindles, right? And they provide feedback to the central nervous system about the position, the tension of the muscles, and they help to adjust for smoother, fine-tuned movement, right? And they also help you coordinate movement. There's a central feedback system. This is in the cerebellum and the basal ganglia. They receive input from the motor cortex and the peripheral sensory system, and their job is to process information. They send feedback to the motor cortex and the brainstem, and again, another way of helping refine movements. Then we have control of the voluntary movement, right? So the schema or the coordination of control of the voluntary movement. So you have some initiation, you have some planning, and then you have some execution. And then we'll also talk about reflex arcs after we understand those first three concepts. But initiation is when you just decide to move, right? You decide to make some movement. That's made in the prefrontal cortex, and then it's relayed to the primary cortex. The planning is that where the premotor cortex and the supplementary motor area, they're involved in planning and sequencing the movements. Then you have the execution, and that's where the primary motor cortex sends signals through the upper motor neurons and the lower motor neurons, and then activate those appropriate muscles to produce movement. And we have other things called reflexes, right? Reflex arcs, for example. And these are simpler somatic motor pathways, right? They include reflex arcs to specific stimuli. Right? We're going to talk about a couple of them in the next couple of slides. Reflexes like the stretch reflex, for example, you can actually manipulate that or observe that at will with what's called the patellar reflex. The patellar reflex is when they hit that little hammer on your knee, and they call it the knee jerk. But these are mediated by spinal circuits, and they operate independently of higher brain functions. So the signals go from the periphery to the central, but not through the brain, and then back out. So giving it its faster response time. Alrighty. Just keep going. This is taking longer than I thought. Oh, so I put a picture here. This is not in your slides as well. I added this to the slide, the neuromuscular junction. It's from your textbook. I forgot to put the picture number, but this is a neuromuscular junction synapse between a motor neuron and a muscle fiber. You see that it involves the release of the neurotransmitter acetylcholine from the motor neuron. We talked about that. I might have mentioned that, or maybe not have mentioned that. But this is where when I say innervation, this is what I mean by innervation, where the nerve fiber actually contacts in this case, the muscle fiber. All right. Basic principles of somatic motor pathways. I'll just read these slides. We're going to get into the reflexes next. So somatic nervous system includes all voluntary motor pathways outside CNS. Somatic effectors are skeletal muscles. Reflex is an action that results from a nerve impulse passing over a reflex arc. It's predictable response to a stimulus, and we can predict these, and we use these for, not we, I'm not a clinician, but clinicians will use these to test, they'll test reflex arc to determine if someone has any injury, or they can tell more than just that. There's some reflexes that doctors will do on newborns to determine, that will let them know how well they'll learn. Anyway, let's not get off topic. Reflex consists of either muscle contraction or glandular secretion. Somatic reflex versus autonomic, which is visceral reflex. So let's go ahead and get into this last section of somatic motor pathways and reflexes. All right, so why do clinicians perform these tests? It's something to think about as we continue talking about this. For example, this is I got a couple of slides on the knee jerk. So, but to get more into detail on the knee jerk, that's the one where you're sitting down, they hit your knee, they hit the patellar ligament, and then you I'll say involuntarily kick, right? So here it says it's a 2-neuron reflex arc. And then possible classifications of the knee jerk are spinal cord, segmental, monosynaptic, ipsilateral, stretch or myotactic, extensor, and deep. And let's jump into these. I'm not going to expect you to know the neural pathway for each of these reflexes, just to know the differences that they exist. So here, this is figure 21-7 from your book, the patellar reflex. It does show the neural pathway that's involved in that, in the patellar knee jerk. But somatic reflexes, we say they're involuntary responses to stimuli and predictable involuntary responses, so we can repeat them, that involve the somatic nervous system they'll result in an activation of a or a group of skeletal muscles. And when you look at this clinically, somatic reflexes become very important because they provide insights into the integrity of the nervous system. And so we'll talk about a few reflexes. The patellar reflex is what we see here. We kind of talked about it a little bit in the last slide. And this reflex it's elicited by tapping the patellar tendon with that little doctor's hammer. I forgot what it's called. It doesn't have the name on it, does it? Anyway, this is a long lecture. You should pause and then get back to the lecture. Okay, you paused. Good. Let's get back. The patellar knee reflex, right? So the doctor hits the patellar tendon with the little hammer. What that does, it stretches the quadricep muscles. It causes it to contract, and that results in that kicking motion of the lower leg. You should try. You can do it on yourself too. If you just sit on the table that's high enough where your leg is dangling, and you can just grab a ruler or something and hit your own patellar tendon. Kind of neat. It just moves on its own, where it moves without you thinking. Right? The clinical significance for the patellar reflex, it looks at the integrity of the femoral nerve, right? So femoral nerve from L2 to L4, and the segments from L2 to L4. So if you had an absent or a diminished reflex, this could indicate you have damage to one of these areas, or to this area, not one of these areas. If you have an exaggerated reflex, this could suggest you have an upper motor neuron lesion. All right. More on the ankle knee jerk. This chapter talks a lot about the ankle knee jerk. The importance of it is that it's an essential part to neurological examinations. It helps localize neurological lesions. It provides information on the integrity of sensory and motor pathways. It helps differentiate between upper and lower motor neuron lesions. And it can indicate the presence of a peripheral neuropathy like spinal cord injuries and other neurological conditions. So a lot of information that can be represented on this. Right? The plantar reflex Babinski sign, I'll talk about this in one of the next a couple of slides down. So let's first talk about, again, this is from your book. This is an original slide from your slides, figure 21-18. The reflex test on side A, I won't talk about that. We talked about that enough. But on side B, you see the ankle jerk, right? So we have the knee jerk and the ankle jerk, or the Achilles reflex, the Achilles reflex arc. And this is elicited by tapping the Achilles tendon at the back of the ankle. And what that does, it'll cause the foot to plantar flexion, right? Or it'll cause plantar flexion of the foot. And the clinical significance of this plantar flexion is that it tests the integrity of the tibial nerve and the S1, S2 spinal segments if you go all the way back up to the plexus. If you have an absent diminished reflex, this will indicate that you have some neuropathy in the lower motor neurons. Again, if you have an exaggerated reflex, you can have an issue with your upper motor neurons. Almost done. Clinical important reflexes, the corneal reflex, corneal reflex, reflex arcs, and the abdominal reflex. We saw, I thought I had pictures on those. Okay. I think I do have pictures on those in the next slide. So I'll talk about them here, and then we'll go to the pictures. The cornea, now I don't have a picture in the corneal, but I do have a picture in the abdominal reflex. The corneal reflex, sensory fibers in the ophthalmic branch of cranial nerve number 5, centers in the pons, and motor fibers in cranial nerve number 7. The abdominal reflex tests for sensory and motor fibers in T9 through T12 and centers in these segments of the cord. Okay, and this is superficial, so they're mainly checking on the skin of the abdomen. Okay, I know I have pictures. Yes, I do. All right. This is figure 21-18, right? Reflex test. No, this is not figure 21-18. Oh, no, it is. Sorry. The Babinski reflex. Yeah, right. So we see the Babinski reflex there on C, and then we see the abdominal reflex there on image D. So and this is from your textbook caption, as an object is moved away from the umbilicus and toward the side, the rectus abdominis muscles pull the umbilicus toward the stroked side. Okay, I have to try that. But let's talk about a few others that are not on this slide, but are in your textbook. The biceps reflex. Your textbook doesn't have a picture on this, but it mentions this. It's a reflex that you test by tapping the biceps tendon and the anti-cubital fossa, and the cubital fossa is just right there where they draw blood. This results in contraction of the bicep muscles and flexion of the forearm. And the clinical significance of that, this is in your textbook, but I'll talk about it since they didn't have a picture. It tests the integrity of the musculocutaneous nerve, and then spinal segments C5 through C6. And there's always whether it's diminished or whether it's exaggerated. If it's diminished or like absent completely, it indicates damage to those areas, and if it's exaggerated, it's going to suggest some lesion in the upper motor neurons. The tricep reflex, if you remember back, triceps on the back side of your arm. This is elicited by tapping the triceps tendon. And that's just above the elbow. So this results in you extending your forearm. Trying to see if I ever accidentally did that while I was exercising. No. Again, we look at whether this is absent or whether this is exaggerated. Wow, my tongue, like, I'm dry. But if you have a diminished reflex in this area, this is going to indicate that you have some nerve damage in C6 through C7 spinal segments, as well as the radial nerve. So it looks at the integrity of the radial nerve and the segment C6 and C7. And again, if it's an exaggerated reflex movement, then that points to an issue in the upper motor neuron, some kind of lesion. The Babinski reflex. Okay, the picture there to the left. I promised I would talk about it. This is where you stroke the sole of the foot from heel to toe, and the lateral border. So in adults, the normal response is plantar flexion, so the toes curl downwards. But in infants, in the cases of upper motor neuron lesions, the abnormal response is dorsiflexion of the big toe, and that's a positive sign of the Babinski sign. Right. The clinical significance of this, I'm almost done. Last slide. This will test the integrity of the corticospinal tracts. Okay. We can go more into those by going back to chapter 20. If you have a positive Babinski sign in adults, that indicates you have a lesion in the upper motor neurons. And that's it. Clinical significance of the abdominal. Good question. It tests the integrity of, I feel like I said this already, of spinal segments T8 through T12. Again, if you have an absence of this reflex, it means you have some kind of lesion. Lesion just means anything from a scar or some growth, anything that's just not normal in the corticospinal tract or the peripheral nerves. All right. And I think that is it. Your book also mentions, I think it mentions the jaw jerk reflex. I should have covered that when we were covering the face, but no. It mentions it, but it wasn't in the slide, so I didn't actually put up another picture on there. But that's it for this presentation. One presentation of two for this week. This took me a lot longer than I thought, an hour and 14 minutes. I was hoping it would take like 30, 40 minutes. Normally, if I do a recording that takes an hour, in class time, it would take me 2 hours because I talk a lot in class. So be glad the recordings are here, and then I will follow up with the next recording on the autonomic nervous system, chapter 22. Thank you for your time.